and kick it off for us. Good morning, Happy New Year. This is the Quality Health Outcomes Committee meeting. It is the first of the year. Way to go, we made another year. Let me just go ahead and go through a couple announcements and then we'll slowly transition into our COVID update. As a reminder, tips for meeting participation: please keep your phone muted when you're not speaking. When you do want to speak, you can either raise your hand or put something in the chat box and I will call on you, so it's a little people than having multiple people speak at the same time. And then when you do speak, if you can please turn on your camera. It's always great to have people's faces, especially when you're speaking, and or we understand there's bandwidth issues, so if you can't, because of technology, understand that. But if you can, turn on your camera. And then also state your name at the beginning. So again, Lisa Bowie, Quality Improvement Director. Let's go ahead and go on to the next slide. And Jennifer, are you able to go to the next slide? Thank you. Here's just a reminder, we'll keep it on all of our slides, it's just kind of the technology tips for Zoom, mute and unmute, all those good things about raising your hands, participant list, chat strings. Just FYI, we have turned on the closed captioning function for our meetings. So closed captioning is now available on Zoom for state government, and we've turned that on. You will find that down on your Zoom panel as well, next to the breakout buttons and other things. So it just has CC, live transcript. The other notation is that the meetings are now going to be recorded and posted online as well. And just as another reminder that the chat string again is public record, because this is a public meeting with OHA. Next slide. Okay,
hey,
so
Lisa.
a couple announcements. Yes.
Sorry, this is Jeannie Savage. I'm still unable to connect by Zoom, but I'm on the phone now. Apologies.
Great, thank you. In fact, the next thing I was going to say is welcome to Jeannie and Doug as our QHOC chair and vice chair. So great timing. We have Dr. Jeannie Savage representing the Trillium, two different regions, Lane County and Tri-County. And we have Dr. Douglas Carr representing Qual Health Alliance down there in Douglas County as our new incoming chair and vice chair for the coming year. So welcome and thank you. I know Dr. Jeannie Savage is on by phone and has some personal things going on, so I'll go ahead and kind of just run the agenda. And then obviously that's also why Dr. Savage can't be, available by camera. Any other comments, Doug or Jeannie, before I go on?
Not for me, thank you.
Proceed.
Great. Okay, so your 2022 QHOC outlet appointments have been sent out. Ideally, if you have somebody in your organization that needs it, you would let Jennifer Bowen or myself know versus forwarding, so we can kind of maintain an up-to-date QHOC list. Thank you again. Jennifer Bowen will be supporting QHOC for 2022. And right now you see emails from Michelle Hatfield or myself, but you'll start seeing them from Jennifer. We are going to plan on proceeding with the February Learning Collaborative, which is focused around traditional health workers. We have a couple CCOs already slated to talk about how they're utilizing traditional health workers, specifically also within their value-based payment programs. So look forward to that. And then as we discussed at the start of the meeting, we'll continue to use Zoom, especially now that we have the closed captioning features. So that will be our platform this year. So we won't be going back and forth to Teams or Zoom or GoTo. We're staying with Zoom. Next slide. Here's just some general announcements. The Oral Health Affinity Group with CMS, OHA, CCOs, local public health authorities, counties, and DCOs will reboot on January 27th. I believe Sarah Weatherson has actually sent out an email to our partners. So if you can reply back to that, that will give us some direction. But as of right now, we're intending to meet on the 27th. And then in your meeting packet, you have the Transformation Center technical assistance as well as the HERC minutes. But just of note, there's a system level social emotional health metric asset map webinar on January 25th. Next slide. Okay, we have a couple items left over from December, so it's just what we call those hanging things left over and follow-up. It's just going to give you some updates of where certain information is at. There's a care coordination and intensive care coordination technical assistance learning collaborative series. So it was a planned series for 2022 calendar year monthly meetings. I talked to the chairs, Jeannie and Doug, and Laura, the behavioral health and quality chairs as well, about this learning collaborative. Basically, I've talked at length multiple times within the agency, within our health systems division partners, our transformation center partners, and then ultimately transformation centers working with the contractor who is going to help facilitate these meetings. We heard in December the need from CCOs to discuss some of the, I'll just call it clarifications and or expectations that are outlined in the 3 OARs related to care coordination, as well as your contract language that's referencing that. It's the hope that that learning collaborative in the first few sessions will address kind of, it'd be more of a, what I'll just call a feedback system in which CCOs can again give OHA some of the operational limitations and or feedback related to those roles. It will not be a rules advisory committee, but it will be an opportunity for CCOs to discuss the existing OARs related to care coordination and intensive care coordination. And then at some point, the agency will then work through what would be the normal rules advisory public committee process to update accordingly and or seek feedback from a broad part of the community. So as of right now, the care coordination and intensive care coordination learning collaborative will be, I believe, later this month. And like I said, the first few sessions will focus on that kind of open dialogue feedback loop. The other item that was carried over technically from November and somewhat from December, I had some updates related to that, is around emergency preparedness. And we learned in June with the heat wave or the heat dome, and then we've learned subsequently with cold weather, the coordination between CCOs and their local partners. One of the things that Dr. Jeannie Savage mentioned was really that connection into your health preparedness regions, so HPOs. In this link that I provided on the website, you will see the HPO regions of Oregon. So of course, it has to be Oregon's way, and the HPO regions don't align to the CCO regions because it's, again, a different body of organization. So what you have to look at as a CCO on this link is the counties that your CCO is in, and then find your applicable HPO. There is an HPO contact on the link with their actual email, and you will want to connect with them on the meeting structures that are set up in your regions to connect to emergency preparedness. So we wanted to make sure you had that link, and I think some of y'all might have been communicated directly from Jeannie as well. And then one of the last other updates related to emergency preparedness is around information in June when it came up around extreme heat weather, and some of the one of the barriers that the CCOs expressed was around having accurate member contact information. One of the potential solutions that were looked into is to potentially add another field within the NMIS enrollment files that would have kind of like multiple contact phone numbers. That has not begun yet. According to my check-in with the NMIS team, I'm still working with OHA leadership within Medicaid to find out kind of the priorities of that technical change. So I will report back more, but as of right now, that has not begun. Any questions about December meeting follow-up or the announcements thus far? And you can raise your hand or go on camera, any of those options, put it in the chat. Okay, let's go to the next slide, please, Jennifer. Okay, so since you all received the meeting information on Friday and the agenda earlier week, we've had some more information related to COVID. Surprise, surprise. COVID is here, Omicron is here, and we've got information for you to help in your region. So I'm going to adapt the COVID update from a whole lot of conversations that have happened. We are going to start with Meg, who is going to talk about hospital capacity. Then we're going to turn it back over to Dawn for kind of a general overview or just announcements. Then I'm going to turn it over to Dr. Kristen Dillon, who will talk about our vaccine rollout and where we are with that. Then I will turn it over to Andrew, who will talk about treatments. Is that correct, Dawn? Monoclonal antibodies, etc. So you're going to have a whole host. We're going to have hospital capacity with Meg. We're going to have John cover it up with general and other updates. Then we're going to go to Kristen Dillon about vaccine, COVID vaccine. Then we're going to go to Andrew about treatments. Okay, it looks like Meg is on camera. Thanks, Meg, for joining on camera, and thank you for stepping in so quickly. Jennifer, Meg, were you able to get some slides together? Jennifer, will you be able to give Meg sharing screen abilities, however all that works? And then just for everyone's knowledge, we'll roll Meg's slides into the broader slide deck and repost it to the website after the meeting. And welcome Jeannie Savage on camera. Meg, I think you should be able to have share right down at the bottom and you can take it over. Thank you.
All right. Hello, everyone. Let me just get this set up to share. And I appreciate your patience and taking a chance for you all to have a pause in what I'm sure is already a very busy Monday. Can everybody see that projected? Is that the right view? And of course, I can't see. Oh, I can see it. Thank you. I got a thumbs up. All right. So my name is Meg Carey, and I am one of the senior health advisors on the COVID response and recovery, and have been involved in the hospital surge incident management team, as well as our healthcare surge incident management team. As you have probably heard, the current forecast is that we will peak with just over 1,600 individuals requiring hospitalization either with or for COVID around the end of January. And this is where we are currently. This is the COVID epidemiologic curves over the entire pandemic. And
you're not projecting that.
Oh, I'm not projecting it.
No, we have the original.
I'm projecting the wrong.
Well, I don't think that it has been given up to you.
Jennifer, are you able to?
Please stop sharing your screen, Jennifer.
Alternatively, you can go up to the view options at the top of the screen and choose Meg Carey's screen instead of Jennifer's. And that will show you what Meg is displaying, although that requires action by every attendee. So perhaps Jennifer, if you could bring up Meg's slides, I think you do have them.
Well, it'd be easier if Jennifer just stop sharing her screen as Doug mentioned. So Jennifer, if you can turn off your screen sharing with the little arrow.
All right, we're viewing Meg Carey's screen now.
All right.
Okay, we're good. Go for it, Meg. Thank you.
Okay, so this is my contact information. Here is the forecast that Peter Graven and all put together for the hospital impact of this Omicron variant. Here's where we are currently in our epidemiologic curve. You can see the logarithmic increase in those who are becoming infected with COVID, as well as while we have an increased number of breakthrough infections among individuals who are vaccinated, as we would anticipate, still the majority of individuals who are contracting COVID at this point are unvaccinated. We're still garnering data on the severity of illness associated with Omicron and how that relates to previous vaccination status, as well as other health outcomes. Here is a zoom in on our epidemiologic curve. Again, you can see that we have at this point over 1,000 individuals contracting COVID, or excuse me, over 10,000, adding an extra zero. These are just numbers that we've never seen thus far in the pandemic. And our test positivity rates are now above 20%. And here's where we currently are with hospitalizations. So again, these are hospitalizations from COVID and with COVID to date. At this point, there are almost 700 people hospitalized in Oregon, either with or due to COVID. During our Delta surge, the peak was just shy of 1,200 individuals. And again, to remind you, the forecast is by the end of the month, we will have over 1,600 individuals hospitalized from COVID. I think also what is notable on this graph, the darkest blue line on the top are individuals who are hospitalized for COVID. The middle blue line is individuals requiring intensive care, and the light blue line on the bottom are individuals who are requiring ventilation. What I think is really stands out to me on this graph is that our hospitals have not recovered from the Delta surge. They were still quite congested prior to this Omicron surge. And this is most recent data about the pediatric hospitalizations. I'll draw you to the y-axis. It is much lower numbers. It tops out as 20 kids hospitalized, both with and due to COVID. This region right here is our Delta surge region. And as you can see, again, there are already significantly more kids hospitalized for Omicron. And we obviously have less pediatric intensive care and critical care capacity in our systems. And so this is also of concern. Omicron is still not affecting all individuals equally within Oregon. These are racial and ethnic data among kids, and similar holds true for adults. The dark blue lines, the graph on the left is pediatric COVID cases disaggregated by age groups. On the right, the vertical three graphs are pediatric COVID comparing kids of color in the blue lines to white kids in the white lines, or in the light gray lines. The top graph is our Alaska Native and American Indian Oregonians compared to white kids. I should say Oregonians and also members of their sovereign nations. The middle graph are Pacific Islander kids compared to white kids, and the bottom graph are Black kids compared to white kids. And you can see still disproportionalities in who is contracting COVID. And there remain regional disproportionalities as well. The darker zip codes have more COVID incidents, and the inset graphs in the Portland metro area and the Salem area just show disproportionalities even within cities. What is being done? There is a new joint ODHS and OHA healthcare surge incident management team, which allows close connection with leadership, with community, and other partner organizations externally and internally to coordinate the response for this Omicron surge across both supporting immediate hospital capacity as well as capacity within our systems across lower levels of care, be it in long-term care facilities, skilled nursing facilities. There's also a plan, as you know, to reach 1 million booster doses, because this, it was projected, could dramatically decrease the number of individuals requiring hospitalization. We are maintaining and increasing the number of surge staffing contracts to support hospitals, long-term care facilities, behavioral health programs. We are also standing up more surge facilities. And then as has been published and is being disseminated, is getting out crisis care guidance, which is frankly the last thing any of us want to do. But there's grave concern that we will need that during this Delta surge. My understanding is Dr. Dillon will speak a little bit more about the vaccination doses. So this is just a graph of where we stand now in terms of how many individuals have received one dose of the vaccination, how many individuals have completed their COVID vaccination series, and how many individuals have received their booster doses who are eligible, disaggregated by race and ethnicity. And as you can see, almost the entire Native Hawaiian Pacific Islander communities in Oregon have received their vaccines, but only 40% have gotten their booster doses. There remain vaccine disproportionalities by zip code as well. The darker red areas are the areas that have the most number of people to reach the goal of 80% of that zip code being vaccinated. And I know this goes without saying, but just a reminder for your communities to get the word out, covidvaccine.oregon.gov has the information of where you can get your vaccine doses and boosters. In terms of surge staffing, so during the Delta surge, we had contracts with national staffing agencies to increase this temporary staffing who could help staff our hospitals as well as long-term care facilities. Those contracts have been extended through the end of March, and we are attempting to field significantly more staff than we did during the Delta surge. The challenge, of course, is that travelers are as susceptible to the Omicron variant as the rest of us are, and there are hospital systems across the country and across our region internationally who are also pulling these traveling staff who are willing to move to meet where the need is most. In addition, we have once again deployed Oregon National Guard volunteers. There are 500 volunteers. These are non-clinical staff who are deployed to our hospitals and our behavioral health programs throughout the state, as well as some in long-term care facilities, but mainly they're in hospitals and behavioral health programs. And then we're also looking to deploy serve or volunteers. In terms of our surge facilities, our hospitals are already at or over capacity. At this point, we have about 200 individuals who are boarding in our emergency departments across the state, waiting to be admitted. We have about 585 individuals who are medically ready for discharge from our hospitals, but who are not able to be discharged because we do not have the lower levels of care that they can discharge to. In addition, in contrast to the Delta surge, our acute care bed, our medical surge beds are filled, and we cannot transition people from our ICUs and critical care units back to med surge facilities. So we're really getting congestion throughout our hospital system. And that's because the medical surge beds are full because we can't discharge people out of the hospital. So we are working really hard to both increase and use to full capacity the surge facilities we have. At this point, there are 183 beds for individuals who are COVID positive and ready for discharge from hospitals in about 10 facilities across the state. There are 124 individuals in those 183 beds. In addition, there are 100.
Thank you for calling Northwest Neighborhood Veterinary Hospital. This call may be recorded for quality assurance purposes. To speak to
There are about 150 beds for individuals without COVID who need to discharge from higher levels of care, with about 100 people filling those beds. The way that the process works to fill those beds is first hospitals make a referral to the program. Actually, I should say first, patients need to be willing to go to these decompression facilities, these surge facilities. Secondly, the hospitals need to make a referral. Third, these surge facilities, which are oftentimes extra wings in long-term care facilities or SNFs, need to accept the individuals into their programs. And they are often looking at how those individuals will fit with their milieu, as well as the capability of their staff to take care of these individuals well. So as you can imagine, individuals with the more complex, both medical needs as well as psychosocial needs and social determinants of health are oftentimes the ones who are the hardest to place. And we are also investigating more options for further increasing our capacity, including increasing behavioral health beds. And that is the end of the slides that I have for this morning. I am certainly available to answer any questions as time allows, or if you would like to email me or Lisa or Dawn, I'd be happy to answer the questions at a later time. Thank you so much for your time. I appreciate it.
Thank you, Meg. Any questions for Meg, since I know she has to jet off to probably more COVID meetings. No surprise for everyone. And if, again, they come in later, then you can always just send them in the chat string and I will collate and get it to the right part of the unit.
Hey, Lisa, this is Jeannie.
Uh-huh.
One of the things we talked a little bit about this morning, Meg, thank you for the discussion, was the multidisciplinary team meetings that had been taking place with hospital systems, state, CCOs, case managers, trying to help that placement. And universally, all of the CCO medical directors felt that that meeting between our case managers and the state and so forth was incredibly helpful in the placement process. and allowed that process to happen more efficiently and more quickly. So what we've noticed in certain areas is that certain hospitals, certain state employees, there's varying levels of involvement and varying levels of who's directing those and organizing those meetings. I think universally we're all excited about that, hoping that will stay going forward. Is there a plan from a state perspective to keep those going forward and directing those in all regions across the state? Or how can we look forward to this kind of continuing?
Thank you, Jeannie, for that. You know, I've gotten to sit on a couple of those meetings when we're trying to problem solve getting dialysis access to individuals. We know that dialysis is one of our one of the sectors that is really struggling to have enough capacity. I don't know the answer to that question, but I will ask around and see what I can figure out for you all.
Thank you.
I may have some perspective on that, Jeannie. Thank you, Meg. And Meg, thank you for stepping in at the last moment. We were going to have Dana Harganani. Dana Harganani until she got called into something, and Meg stepped up at the last moment this morning to cover. So thank you for coming. The regional hospital gatherings, I anticipate proceeding. Meg, is that not the work that Dwayne does with his group?
There's two groups. So there are, thank you, Dawn, for making this clarification. So this is exactly right. There are, the state is divided into 6 regions, and there's a designated regional resource hospital that can coordinate and help level load and provide mutual aid within their regions. And then each regional hospital meets in a statewide call, and we help problem solve kind of global statewide issues as well as level loading and mutual aid across the state. And those meetings are happening. And then there were meetings with CCOs about particularly problem solving discharge of their members to assuring their members get the services that they need to safely discharge and to heal and recover. So maybe I was conflating the two.
Then the discharge assistance team calls are a different, that's a different set of calls, but that is the one that that I believe has involved, when it's talking about COVID overflow facilities, we're talking about QHOC involvement. Jeff McWilliams, are you on the call and able to speak to that?
I am, thank you. I'll try to put on my video too. So the meetings that QHOC was doing with discharge assistants and the hospitals are no longer occurring. That was a decision made by DHS. We are currently supporting the individual decompression units in order to assist with discharges out of the decompression units. So in order to free up decompression unit beds so that people can come out of the hospitals into those beds. So to put it into the data that Meg was talking about, we're involved with the 151 COVID negative beds at this point. And did that answer your question?
It clarifies what slice QHOC is still involved with. And then it sounds like there may be some additional information that would be helpful to this group around the hospital discharge coordination meetings. Is that right, Jeannie? Is there still pending information there that we haven't gotten? Yeah.
Yeah, exactly right. Yeah, I mean, those meetings were incredibly helpful. I don't know if they were the DAT meetings per se, but they were mostly with legacy and state providers and the CCOs, and they in my region, in the Tri-County region, were incredibly helpful. So
let's be sure that I have clarity on which ones those were, and I'll reach out to you offline to make sure of that, and then we'll get some more information out to everybody.
Sounds good. Thank you.
Okay, well, thank you, Meg. It sounds like we have a couple, at least one follow-up item, and I'm sure it's not just to the Tri-County. So we'll figure out where those coordination meetings are happening and who is leading them and how to get to the table. I'm going to announce a couple things before I turn it back over to Dawn for the broader COVID update. Meg mentioned the interim crisis care guidelines. So in your QHOC follow-up email, you'll get, and I'll actually send some of it as early as today, and then we'll see how much follow-up will come after. But you will receive the interim crisis care guidelines that were released on Friday. You probably heard about it in the news. You all will be getting those. In the information that I'll be sending you, Dr. Dana Harganani and leadership are actively talking about them right now, which is why Dr. Dana Harganani cannot be with us. But I am going to be assisting Dana in the committee that's also coming, that was announced on Friday. So you'll get a few links from me. You'll get the interim crisis care guidelines. You'll get 2 links. One of them is about the resource allocation advisory committee that OHA is forming in the coming weeks. In fact, the call for applications was just sent out. And in that call for the applications, we would love for you to spread it amongst your community, your providers, your practices. We're looking obviously for broad-based community, tribes, as well as ethicists and those in emergent type trauma care. So you will see that kind of details in the call for applications. And if you have any questions, you can email me and I can get that to Dana, because what I didn't announce at the beginning and failed to do was I'm getting pulled back into COVID duty. So for all those here at QHOC, my time will be limited, and I will I'm still trying to figure out the staffing and support of this meeting as well. But know that if you need help with the resource allocations or interim crisis care guidelines, you can come to me, because that's what I'll be working on with Dana. And then if you need help with quality, you can come to me and I'll still find out where it's happening. So there's new updates plus interim crisis care guidelines. Anything else, Dawn, that I might have forgotten?
We'll just keep trying to pull the pieces together and limit the number of balls that get dropped, especially as surge is happening, and OHA and DHS are both now also needing to staff that surge IMT, the incident management team that Meg talked about. Lisa's getting pulled in, as are a lot of folks. So we'll do our best to keep things rolling and keep being responsive.
Okay, so I'm going to turn it over to you, Dawn. Just so you know, Dr. Kristen Dillon is actually speaking to, I don't know if it's the governor's office or leadership right now, so she's unavailable, but Jamie Wright is available and on the call. So after you give your just overview of COVID, then you can pass it over to Jamie, and then after Jamie is Andrew. So back to you.
All right, thanks everybody. Meg did a great job of providing the fairly gloomy picture, although there is some reason to believe that cases might spike super high and come down without the attendant number of hospitalizations and deaths that we might have anticipated with Delta, because it may have a lower overall severity, but that has yet to play itself out. Obviously, we can cross our fingers. The couple of things that I can touch on, a couple more things after Jamie gives us an update. And Jamie, I do appreciate your covering again for Kristen Dillon on very short notice, as she is stepping up to the next plate and sharing with us the information about vaccination and boosters, which we know do have good effectiveness against Omicron. So thanks for being with us, Jamie.
Yeah, you're welcome. Dr. Kristen Dillon is in that same meeting with Dana. And so when she's fresh off of 2 weeks of vacation, so just trying to get up to speed, and it's been a busy 2 weeks in her absence. And so I think I'll share my screen to show these slides. let me attempt to do that here. And let me know if you guys can see. I think it was up earlier showing this COVID Oregon and OHA update. Does that look like that's what you're seeing?
Yes, if you could put it in presentation, or there we go. Thanks.
Does that work? Okay, great. And since I have never been to this meeting and I didn't know what to expect, I had our comms person kind of do like a general slideshow. So there's a couple slides that are definitely going to repeat some of the things that Meg said, but we'll just kind of move through them. And not quite knowing what you guys needed from me, I'm happy to take any questions and attempt to answer them. And I can have Kristen too, and I follow up with any other questions you guys might have. So as Meg already commented on a lot of things, you know, we are very much in the surge. We're doing a lot of prep. And how we're responding, we have that big 1 million goal. So working on boosters has been a huge part of our planning since about mid-December when we found out the news for the projections. Really trying to ask vaccinators to double or triple their weekly administrations. And part of that too is increasing capacity to do that. We've been trying to work on a workforce augmentation plan to help vaccinators double or triple their capacity. Also, you heard, you know, tons of workforce augmentation around hospitals, behavioral health, et cetera. We have about 500 staff coming from the National Guard that we're going to be deploying. You'll also see that besides our high volume vaccination sites, we've been expanding those throughout the state. 3 more have been added this mid-January for a total of 12. We have 3 FEMA mobile vaccine units that are also coming back on contract. And then we're adding high volume testing to quite a few of the vaccination sites. So vaccine supply and vaccinator capacity. So we've been doing a great job at getting vaccine into the state. We've been really on top of that. I know right after New Year's, quite a few people were running out of some Pfizer trysts. And to give some context to that, you know, to prep for the transition over to the new Pfizer trysts formulation, the CDC required that we decrease our supply of Pfizer trysts to be able to start ordering. And that ordering didn't become available until midnight of Christmas Eve. That's when everyone was already on holiday. So to be able to order, we couldn't put in those orders until Monday, the 27th. And then due to weather and holidays and blackout dates, it was very unlikely that we would get much vaccine in the state until after New Year's. So the first date projected to get that Pfizer tryst was almost January 5th. And then a lot of severe weather was happening and that delayed it even further. I think as of now, everyone's feeling pretty good about our vaccine supply again. So that was a bump. And to prepare for that in the future, OHA has decided to take an extra supply of vaccine and store it with cold chain technologies. They have a good amount of space for ultra cold freezer space where we can store some extra vaccine. So if something comes up again, such as happened, we hopefully will have more vaccine to move around. And I know our Oregon immunization program team has been working very tirelessly to make sure that we get vaccine and move it around. And cold chain technologies also has been used, and you may have heard this, that they're being used to go to different sites and vaccine providers and get extra vaccine and reallocate it places when needed. So we continue to do allocations. Right now, CDC has it set up on a bi-weekly basis. So we just did allocations last week and got in over 150,000 doses of pediatric Pfizer, Moderna, and Pfizer trysts. Altogether, it was over 150,000 doses. As soon as we heard about the surge coming in the projections, we really wanted to focus on long-term care facilities and reaching out to them. From an update just this morning from the vaccine equity teams, they have reached out to all 699 sites to make sure that they have gotten booster clinics scheduled or to help them do that. They've also been using some of their mobile vaccine units from OHA to go and make sure that those boosters can be provided at those long-term care facilities, obviously because this is a high-risk population who really to prevent more hospitalizations, we really want to make sure that they have their boosters. So if you look at the slide, it shows that 79% of the long-term care facilities have completed at least one booster clinic, and another 7% are currently being scheduled. So we're continuing to do that work. Some of these are repeat slides because Meg was so on it with her data. You can see the booster rates and where we're at. I definitely know that some of our projections and hopes for boosters over the last week have been not as high as we hoped. There's been a lot of weather closures, not only for our vaccine sites, but for everyone across the state. Here's that same slide that Meg showed for adult and pediatric vaccination rates. Still working to push everyone. Obviously, we see that huge jump with pediatrics because it's so new for the 5 to 11-year-olds. And here's some of that race and ethnicity data that you already saw. Here's across the counties. And then here's our running average. And all of this data is through January 4th. I do want to offer that I can get you guys this afternoon updated slides be up to date as of today, but that data is actually being updated probably as we speak to Tableau. So if you guys are interested, I'm happy to have all these slides updated and sent your way this afternoon. So then also, you know, we have tests coming. We've already distributed over 1 million. We just got 12 million at-home COVID tests came into the state. That's 6 million test kits, and they each contain 2 tests. And so we're going to be distributing those. They've already started. We didn't get all of that 12 million at one time. They're coming in shipments, and so they'll be allocating that. I don't know if I touched on everything you guys really would love to know from Kristen, but happy to answer any questions the best I can.
Thanks, Jamie. There's actually one question that already has come in the chat box, so I'll go ahead and ask it of you. And for those that are online, be sure to put it in the chat box or raise your hand and call on you. The question related to, is there a list of the 9 sites and is it like on the web, or can you add it to the slide deck?
The high vaccination sites? Mm-hmm. Yes, I can email that list and then you can send it out. Would that work?
Yes, if you want to go ahead and do that. And then what I'll do is I'll also add it to the existing slide deck that we'll update. We're going to update the slide deck shortly after the end of this meeting with Meg's slides. And so I can just slip in a slide that says high vaccination sites.
Of course.
Any other questions for Jamie?
Vesh has a question.
Yeah, hi. Thank you, Jamie, for your presentation. One area that you touched on there was the supply of testing kits. I know that from even from a professional standpoint, from clinics and hospitals, they're really still seeing a shortage for enough testing supplies, even just to test staff who need to come back to work and getting that done. And these are going to be ongoing needed because they, you know, just having some kits, they run out very quickly and then you need more again. The surge is not over. Mm-hmm. You know, so there's definitely, you know, difficulties around the country to find testing supplies for the average individual. But even in the clinic setting and the hospital setting, I think providers are needing supplies to just keep their staff from being, you know, affected and not being able to come in. So I'm wondering about, you know, what the ongoing plan may be to keep supplies replenished, because it is still very, very tight.
Yeah, and if this is a decent enough answer for you, I'm happy to raise that up to those higher than me to talk about that conversation. I know everyone's feeling it. I just had to try and get my kiddo a test to be able to go back to school, and I know that the clinic was running out of them. So, and I can't imagine for the hospital surge how you manage that with your staff. So happy to raise that up to some other people who make those decisions.
Thank you.
Of course.
I have a little bit of insight on the question that Bhavesh raised. The 12 million tests that the state has received. One of the groups that will be prioritized. Children, please, quietly right now. one of the priority groups for consideration by the state for those 6 million test kits, 12 million tests, is going to be those healthcare workers who are continuously exposed or infected over the course of the next coming months, and the need of healthcare facilities to keep their staff tested regularly and frequently. So please know that that is being built into that plan, and you and I suspect everybody will be hearing more about that as it works itself out.
Okay, thank you.
Thank you. Any other raised hands or questions for Jamie?
I'll take the silence as a no. I'm going to jump to my next meeting and I'll follow up with the things we talked about. Thank you guys so much for your time.
Thanks, Jamie.
Thanks, Jamie. Again, on short notice, new to the system and trying to cover. I hope that was useful information for everybody. Lisa, what's on tap?
Well, we have a moment. One, we could ask, we could transition to Roger for a P&T update, because we know Andrew can't join for till 11 o'clock, or we can take a break. So I'm going to look to our chairs to tell me what you'd like to do. We know that the next COVID update relating to monoclonal antibodies and treatments is he's not available till 11.
I also have a couple more brief updates that I could offer before we go to break, if now's a good time.
Yeah, because I didn't actually schedule a break. So what do y'all want to do? Dawn go and then take a 5-minute break? Okay,
Sounds
Dawn,
good.
you go. We'll take a 5-minute break and we'll try and reconvene about 11.
Okay, I wanted to follow up on a couple of things. I hope everybody had as happy and safe a holiday season as you were able. It's nice to see you back, and it's hard to have to come back in the context of surge and jump right in the heat of it without having a chance to take a breath and express gratitude for the work through the last year, and acknowledgement of what we hope to achieve in the coming year, and gratitude for the collaboration and partnership that we are all hoping to foster here in this environment. I appreciate the work that y'all are doing and how hard it is, especially at the interfaces where, for example, we're trying to support the discharges from hospitals. Over 500 people on a list saying that they're delayed from their discharges from hospitals, knowing that the nursing facilities are both full and short-staffed, and the decompression facilities, one batch of them with COVID positive and one COVID negative. Really complicated, a whole lot of work that everybody is doing. Lisa, would you make sure that somebody forwards the invitation to Andrew Gibler so that he can come on for the therapeutics update? Or Jennifer? A couple of other, thank you. A couple of updates quickly, just to touch on them and let you know that they haven't fallen off our radar. Long COVID is to be covered per the CMS directive, and there are probably some details to be worked out about that. That's a conversation that we're getting up and running at the state level. Clinical trial coverage looks in some ways very similar to what we already have in place, but that memo regarding the clinical trial coverage requirement is there from before the holidays for your essentially your consideration and making sure that you're in alignment with its requirements to the best of your ability to interpret. And we're going to work out some more details in a work group at the state. And the hospital discharge payments, another conversation that is beginning to take off here now after the holidays. So we'll be taking that up with a variety of the CCO meetings, CCO ops this week, as well as internally here at OHA to see how the payments for hospitals for those patients who no longer require hospital level of care but are occupying hospital beds, how is that discrepancy going to be resolved? So please be aware that those issues have not fallen off the radar. They're not resolved yet. And that concludes my updates and reminders and gratitude a little bit. Happy to take any questions that I'm able to field before we go to break, if desired.
I don't see any hands raised. We'll take a 5-minute break. Y'all can absorb the mounds of information around COVID we just sent you. And then we'll come back with Andrew and talk about COVID treatments. And then we'll go to Roger Cetron for P&T and just keep rolling with the HERC after that. So have a nice stretch break. We'll see you in a little bit.
Thank you, Lisa.
Yep,
Andrew,
I'm here.
Andrew. Great. Okay, thank you for being flexible and again, stepping right in. Jennifer does have your slides and is able to advance. Note that the speaker says to be determined. Sorry about that. But as we are lucky to have Andrew fill in. Andrew, if you wouldn't mind introducing yourself and kind of your role within the crew/IMT, that'd be great. And then you can just let Jennifer know to advance slides as you like.
Yeah, thank you. My name is Andrew Gibler. I'm the TBD speaker for today. I'm the clinical pharmacy manager for OHA. And I'm glad to be able to join you today. I'm just going to speak quickly, nice overview over the current therapeutics for COVID-19. We will, I know some of you have probably gotten a review of this already, and so I appreciate that. I'll try to go quickly, but with the Omicron variant, just review some of the therapies that we know to be effective against this particular variant. And I'm sorry, I am a pharmacist by training. I've been with OHA since July, previously a pharmacy director at Legacy Health. The next slide, please. The current federal allocation that we've received last week for the monoclonal antibodies are listed below. So we still have tight allocation of all 4 monoclonal antibodies, Regencov, Bam-Edi, and Sotrovimab for treatment, Evusheld for pre-exposure prophylaxis. A little bit more allocation there. Next slide, please. And then we have 2 oral antivirals, and these are numbers of courses, not number of tablets. And we've got an allocation of both Paxlovid and Molnupiravir. Those, as you may recall, were in the news as receiving EUA right before the holidays. Shortly, Paxlovid first, and then Molnupiravir. Paxlovid is a Pfizer product, Molnupiravir is the Merck product, and I'll briefly touch on those in a little bit. Next slide. And the next slide, please. That's just a mechanism of action for monoclonal antibodies, which I think most people are familiar with. They inhibit the entry of the virus into the cell. So Sotrovimab is the monoclonal antibody that we currently have that we know to be effective against Omicron. It is available and administered intravenously, and like the other treatments, is for outpatients, is for mild to moderate COVID-19 infection. So patients need to have a positive test, but the ones that we know to have benefit are the ones that are at high risk for severe illness of COVID-19. So those that are at risk for hospitalization or death if they were to become infected. So these patients, if they present early with mild to moderate symptoms, are eligible for Sotrovimab. Next slide. REGEN-COV is the other monoclonal antibody. We do not believe it to be effective against the Omicron variant, but it was very effective against Delta. It's available, still available. We still receive some allocation of it. It can be administered, of course, both IV and subcutaneous, which makes it somewhat unique and can be utilized in outpatient settings rather easily versus the treatments that are only available to be administered IV. And again, it's for these eligible patients need to have mild or moderate symptoms of COVID-19, but also be at high risk for development or progression to severe illness. The other indication is for post-exposure prophylaxis, which is unique to REGEN-COV and BAM-EDI as well. So again, more utility with the Delta variant. Next slide. And then bamlanivimab and estivimab is a third monoclonal antibody available only IV for treatment and prevention as well, just like REGEN-COV, and with the same indication, mild to moderate COVID symptoms, but at high risk for development to severe disease. Next slide, please. Some of the side effects are listed there. They're very well tolerated in general. There is a rare risk of anaphylaxis, just like with many monoclonal antibodies, but they tend to be, at least initially, generally well tolerated, and we've been seeing a lot of experience. I think some of the providers that are using these have had good experience with them overall. But we, like with the other treatments, we encourage any reporting of adverse effects to the FDA. Next slide. Evishield is unique. It's the fourth monoclonal antibody because it's has an indication for pre-exposure prophylaxis, and this is really received an EUA just last month, just a few weeks ago, and it's a nice option for people that have moderate, severe, or severe immunocompromise and aren't expected to develop a good reaction to the vaccine. And good response to the vaccine. So this is an opportunity for those patients, or for patients that just have contraindications to a vaccine, COVID vaccine. This gives them an option for pre-exposure prophylaxis treatment, and we believe it to be also effective against the Omicron variant. Next slide. And some safety considerations there. Next slide. I think there's a cardiovascular risk that was shown in the studies. I think anyone using this should be aware of and review the fact sheet about some of the cardiovascular issues with that risk with that monoclonal antibody. So we'll move on to the intravenous antiviral, which is remdesivir by Gilead. It was recently published. The study was recently published in outpatients. We've used it in the hospital for a while now. Since 2020, we've been using it in hospitalized patients. It's available commercially. It's not distributed by the HHS. But in this study in outpatients, we've in 12 years of age and older, in patients, again, the same population, not hospitalized, but with mild to moderate symptoms of COVID-19, early in symptom onset, but with high risk of progression to the severe illness. We found it to be very effective in preventing hospitalizations. The outcome was hospitalization or death. There were no deaths in either group, but placebo or remdesivir, but we saw that it reduced hospitalizations tremendously by about 87%, I think. The downside is a logistical barrier of a 3-day course where you receive 200 milligrams IV on day 1, then 100 milligrams on days 2 and 3. So in the study, it was studied in patients coming to the outpatient infusion centers, or who were in skilled nursing facilities, or had home infusion services set up. And so we would see likely in right now with those same patients, that would be kind of the areas where we would have opportunity to administer remdesivir. Next slide. And just the data there that shows the patient population studied. They were mostly, the risks were mostly diabetes and obesity and hypertension. Most patients received the remdesivir within 5 days of the course. Is about 3 to 5 was the range of symptom onset to the first dose of receiving remdesivir. So it is time sensitive again. And you can see a number needed to treat of 22 to prevent either hospitalization or death in patients treated with remdesivir. Next slide. And these are, again, the 2 oral antivirals. Next slide. And the same indications that we've seen with some of the monoclonal antibodies. Time sensitive, symptom onset within 5 days. They're presenting with mild to moderate infection, but they're at high risk for severe illness. Next slide. And Paxlovid, there's some, I guess we need to be aware of both kidney and renal function and really drug-drug interactions. It's metabolized with ritonavir, is boosted with nirmatrelvir, is boosted with ritonavir, and we've got a lot of potential drug-drug interactions in some patients. So we really want to make sure we have an understanding of what medications they're on and review those before prescribing Paxlovid. Otherwise, we can really run into issues where patients could develop toxicity to the drug, or it could be completely ineffective. Next slide. Molnupiravir, it's indicated only in adults, not in children, not in pregnancy. But it can be. I think there's some concern around teratogenicity and some growth plate issues in children. And so we really want to reserve it only for adults presenting within 5 days of symptoms at high risk, again, for severe illness. And what's unique about this drug is because of its modest efficacy and some of the safety concerns that have been presented, that we really want to make sure there's no other FDA authorized treatment options available to the patient at the time before we would prescribe molnupiravir. And so that's likely the case, would not be uncommon case when allocations are limited with all the other treatments, but it's something to be aware of, and would be probably the least preferred option for treatment of COVID-19 in most patients. Next slide. Some safety considerations around because of the mechanism of action, some different toxicities that we want to be concerned about with fetal harm and bone and cartilage toxicity. Next slide. And so these are just briefly, again, a review of the agents that we believe to be effective against Omicron. Evusheld, again, is for pre-exposure prophylaxis only. The others are available for treatment. And the NIH has provided some guidance on that, where if there is allocations are limited and you don't have availability of certain agents, they do list kind of a preference for treatment, where Paxlovid would be probably the most preferred agent, just because it's very, very convenient as an oral therapy, and it's very effective. So sotrovimab and remdesivir, which also are just as effective probably as Paxlovid, but they're IV, with sotrovimab being only 1 dose, but remdesivir being 3 separate doses over 3 days, which makes it very, very inconvenient compared to Paxlovid and sotrovimab. And then molnupiravir kind of being the other 4th line option, but still very convenient for patients, but very modest efficacy, we think, compared to the other agents. Next slide. And here's kind of the tiers that have been developed that are guiding us on the prioritization of what of treatment. Next slide. And then OHA's methodology of allocation, which which is centered on equity. And so the distribution is prioritizing right now tribal clinics, federally qualified health centers, local public health departments, and hospitals right now, and before we are able to really open it up. And once supplies open up, we will there can be broader distribution of these products. So appreciate the patience that we have to deal with right now with allocation. Next slide. And again, with the 2 oral antivirals, Paxlovid, because of its allocation restrictions and likely the demand really surpassing the supply, there is some restrictions right now where we're kind of focusing our efforts with FQHCs and tribal clinics and some regional emergency departments. And then molnupiravir is more of a broader outreach. Demand appears to be a little bit less with that drug, but prioritization will be similar to Paxlovid if we do get a reduced supply. So next slide, please. They come in shipments of 20, both Paxlovid and molnupiravir treatment shipments of 20 courses, and so that's something to keep in mind. For sotrovimab, ongoing shipments will ensure larger number of doses at larger health systems, tribal clinics, and FQHC partners with IV intravenous capability, and some independent practices serving FQHC-like populations. Next slide. And this is an email. I'm sure many of you have it, but it's a nice email to use if you have specific questions, and your questions will then be distributed to appropriate people within OHA that might be able to help you. And we encourage you to ask questions in the email, through the email if possible, and we'll get those respond as quickly as we can to help you care for your patients.
Thank you, Andrew. You have questions already in the chat box, and just a reminder for participants, you can put it in the chat box or raise your hand. I'll go ahead and get the first one for you. Are these monoclonal antibody drugs you covered in any way related to DENOSUMAB, otherwise known as Prolia?
I'm maybe someone else is on the line may know, but I'm not aware of any relation or similarity between Prolia and the monoclonal antibodies that we just reviewed.
That's correct.
Okay, great. And let me get to the next question. Good morning, Andrew. Does OHA have any billing guidance for pharmacies dispensing molnupiravir? Yeah, there you go.
Yeah, I think that's something we are definitely working on. The drug is provided at no cost to us, and we're allocating it to pharmacies, so they won't be able to get reimbursement for any drug costs, of course, but we're looking for how to reimburse for the dispensing. And so that might be a limitation for pharmacies if those reimbursements are low. And so that's something that we're considering, but I don't have a response for exact guidance on billing yet, but I will. That is something we're aware of and are working on.
Thank you. And then you can just route any of that updates if it does change any of that billing guidance. You can just send it on my way, and I can pass it on to all
Okay.
the participants. And I've listed it down as a question / follow-up item. So you may hear from me. Any other questions for Andrew on COVID treatment? Thank you, Andrew, for stepping in. If I get anything throughout the meeting, I will pop it your way. And then we will hear you probably someone from the team in the future. So thank you again. I'm going to go ahead and transition us from COVID to pharmacy and therapeutics. So someone in the therapeutics land, but this is just broader than COVID. So Roger Citron, are you still on the line? And
I am. Can you hear me okay?
Patient. Yep. Thank you for being patient. Jennifer can go ahead and advance the slides at your direction.
Yeah, appreciate it. Again, Roger Citron, Director of the Drug Use Research Management Program, and we help administer the P&T meetings. Next slide. So we had a P&T meeting in December. The recommendations were put forward to direct round and approved on December 6th, and that provides a link for you to review those recommendations. Next slide. One of our standing topics is new oncology agents. We add them to our oncology PA criteria. So 3 new agents came to market, and there's a link again to our searchable web app that'll take you to the oncology drugs. Next slide. Also on the consent agenda, we have orphan drugs. 3 of those came to market, so we add them to a table. It shows their approved indications and ages, and this is a link to that criteria. Next slide. We did a literature scan of the inhaled cystic fibrosis. Based upon the information, we made no changes to the clinical evidence. We did recommend maintaining inhaled mannitol as a non-preferred agent. We reviewed the cost in executive session, made the recommendation that tobramycin and sodium chloride be non-preferred, Kitabis on its generic versions be non-preferred. I unfortunately put an old link there from a previous slide. So in the chat box, I just put a link to an accurate link that'll take you actually to the class. So you can see the preferred and non-preferred status as well as associated PA criteria. Next slide, please. We did a review or an update to the Evkeeza prior authorization. Within that, we updated question 3 to require 12 weeks of maximally tolerated therapy. Gives you a better understanding for the clinical need. And the committee also recommended implementing renewal criteria and asking a question about evaluating for pregnancy. Next slide. Spravato, it's a carve-out medication when billed as a pharmacy claim. So we did have some requests that came through with members that had a history of substance abuse. So we did a review and clarified the appropriate maintenance dose and use for patients with the history of substance disorder in the PA criteria, the safety edit. Next slide. We did a drug use evaluation for PrEP. HIV pre-exposure prophylaxis. The recommendation from the committee was to develop an educational retroderm program so we can improve provider knowledge for PrEP with patients. Both we've seen testing for sexually transmitted infections or if they have a diagnosis of a high-risk behavior. So we're working on developing that DUR program at this time. Next slide. Did a glucagon class update and an evaluation of the new drug Zegalogue. Based on the clinical evidence, no changes to the PDL were recommended. The recommendation was to maintain Zegalogue as non-preferred. We looked at the pricing in executive session and no other changes to the PDL class were recommended. Next slide. We did a PNH class update and a new drug evaluation. Recommendation was to revise the Ultomiris PA criteria because of its expanded indication and use in pediatrics. So we updated that along with the indication. We added Empaveli to the biologics for rare diseases drug class and implemented proposed PA criteria. We looked at costs in executive session and the recommendations were to maintain Empaveli as non-preferred on the PDL. Next slide. Did a class update for the gonadotropin releasing hormone modifiers and a new drug evaluation. The recommendation was to split out the PA criteria. So we're now evaluating with criteria of the antagonists independently and separately from the agonists. So we have new criteria. And we looked at the comparative cost in executive session, and the recommendation was to maintain Myfembree as non-preferred. Next slide. Did a growth hormone class update in new drug evaluation. The recommendation was to maintain Skytrofa as non-preferred, to update the growth hormone PA criteria to include Skytrofa. We looked at costs again in executive session, and no other changes were recommended to the PDL. Next slide. Biotherapy literature scan and PA update. Again, no changes to the PDL based on the clinical evidence. We did modify the Ocaliva PA criteria for the recommended dosing parameters and safety precautions. After review in executive session, no other changes were recommended to the PDL. Next slide. That was it for the December meeting. The next meeting of the P&T committee will be in February on the 3rd. We just posted the agenda and the final documents on January 4th. Again, here's a link to the search or to our website where you can review those documents, materials. Next slide. Making another call, plea for you. If anybody is aware of any actively practicing physician, MD or DO, that would be interested in being considered for appointment to the P&T committee, we're looking for 2. They're 3-year terms. They have a commitment to meet 6 times. We meet every other month on the even numbered months from about 1 to 5 o'clock. So really we'll look for, if you know anybody within your systems that have an interest in evidence-based medicine and some availability to help with this important work, boy, please get them in touch with me. And with that, I'm open to any questions. Next slide. Thank you. All right, thanks very much.
Thanks, Roger. Let's now transition over to the HERT. Next slide, Jennifer. And Ariel, are you up? You're up.
I'm here. Can you all hear me?
We can.
All right.
Thank you.
Hi, everybody. Happy January. I'm Ariel Smits, the Medical Director of the Health Evidence Review Commission, for those of you who don't know me. Next slide, please. So everything's getting canceled. It's a theme you'll probably see with OHA. We canceled our January meeting as well as our February EGBS meetings because of the COVID surge and trying to free up resources. So our January VBS HERC is canceled. Our next meeting is scheduled for March. Next slide. Lots of things on the March agenda that were on the January agenda. There is a new state law about newborn home visits. We're going to be adding a couple of codes to allow for newborn well child checks in the home, as well as postpartum checks. With items that we didn't get to in November, things like platelet-rich plasma, which would be to formalize our non-coverage, radiofrequency ablation for renal tumors, which would add coverage, pelvic vein congestion would just clarify that we don't cover this. Breast MRI guidelines is actually a pretty significant reworking of all of our breast screening guidelines to make it clearer to everyone when we cover breast MRI. And then also breast reconstruction after lumpectomy is a little unclear. There is a federal law that requires breast reconstruction after mastectomy. So we're going to clarify whether that also applies to lumpectomy. Next slide. Other items on our March agenda, dorsal rhizotomy for spastic diplegic cerebral palsy. This is brought to us by an advocate. This would actually be a line move, so it would be a biennial review change that would take place in a couple of years. We also had, after the slide deck went out, one other biennial review, which is our agenesis of lung line, which has no claims. There's no treatment for it, so we're going to get rid of that line. Autoimmune encephalitis placement, we're still waiting on the outcome of our PANDA-PANS, which is pediatric autoimmune disease after strep infection. that whole review to finish, and then we need to work on what autoimmune encephalitis is a different entity, pretty significant, pretty severe. So it's probably already being covered because most of these patients would be ICU level care, but we just wanted to make sure that that will happen. We've been asked to look at actinic keratoses again. These are precancerous lesions. We currently don't cover treatment. We've been asked to look at foot arthrosis for foot arthritis, which we currently don't cover. Intraopathic arthropathies, there's a suggestion we should cover that with other autoimmune sort of GI issues. Currently, we cover erythropoietin if you have chronic renal failure, a couple coding changes that came to us as a question about that. Then we are going to clarify our lower urinary tract symptoms from enlarged prostate guideline and look at sensory integration therapy. Just of note, one of the things that the HERC staff has been pretty involved in the last couple of months is working with advocates and outside folks to looking at our below the line lines and diagnoses to see if there's anything that needs to be moved to covered areas. So you might see some things just coming up from that review. There's quite a few straightforward things that we found as we were going through those uncovered lines that were very inappropriately there, like viral myocarditis was on the cold line. So things like that just need to change. So there's a lot of, you'll see a lot of straightforward things hopefully coming out of the March meeting. Next slide. Just to reiterate, I think I showed this to you at our December meeting, although it was we had a very short time. So I think I just kind of let you all know that this existed. The evidence-based guidelines subcommittee has finished the review of high frequency chest oscillation devices. These are kind of colloquially known as chest vests. They are recommending treatment for people with CF when they either can't tolerate or can't receive or have failed PT or home chest physiotherapy. We are also recommending for non-cystic fibrosis bronchiectasis when there's a whole series of things. They have to have it confirmed on a CT scan, and they have to have evidence of chronic lung infection, as well as daily productive cough. And again, they have to have failed chest PT or have it contraindicated or have no one available to perform it for them at home. Next slide. And then finally, covering it for those patients with neuromuscular disease, if there is evidence of chronic lung infection. As we all know, neuromuscular diseases are a very heterogeneous, very large group of diseases. So this would be those that are associated with chronic lung infection. And again, those people who can't do home physiotherapy or it has failed. We are not going to expand chest vest coverage to COPD. So this recommendation will be presented to the HERC for final approval, as well as being made into a guideline for the prioritized list at our March meeting. Next slide, please. Future topics that are kind of on our radar, solid organ transplant line review. We're working with the Health Services Division about whether this should just be a rule review or whether we actually need to do some changes in the prioritized list. I'm sure you're all aware that our solid organ transplant rules are woefully out of date and need revisions. And we're kind of working with our partners to see the best way to do that. I mentioned before the below the line complications review and the autoimmune encephalitis prioritization. Those are probably going to be future topics. Next slide. So EGBS was scheduled for February 3rd as a virtual meeting. It has been canceled. OAJ is trying to basically divert all resources toward this current Omicron surge. So this EGBS meeting will be held in April. It will continue to go over our PAN-to-PANS coverage. The proposal that came out of the last meeting was to cover IVIG and plasmapheresis if 2 pediatric subspecialists recommended it and the child has tried and failed 2 less intensive therapies. and reassess every 3 months with non-coverage for surgical interventions like tonsillectomy and adenoidectomy and long-term antibiotics. We have received a copious amount of public comment. We will be working with the Center for Evidence-Based Policy as our usual process to go through that copious public comment. One of the main issues that has been brought up by most commentators is the inability to get two pediatric subspecialists to see a patient, let alone kind of agree on a recommendation. So that recommendation may be altered. But again, this is, we have just closed public comment. We will be doing our public comment disposition on our usual. And rather than talking about this in February, we will talk about this in April. So just keep tuned for that. Next slide. This is exactly what I was kind of talking about. This is the PANS guideline for the two specialists and having to fail. There's also a little question about whether or not you have to fail steroids, because that actually might be, if you respond to steroids, you might respond to IVIG, et cetera. So there's a lot of working that needs to go on with this. Next slide, please. But after PANS, EGBS actually has kind of a hiatus of topics. So if you have anything that you feel would be appropriate for the EGBS process, so either conflicting or difficult to determine evidence base, or something that would benefit from a lot of formal public input, a lot of some things that may be controversial or that just are a very high visibility that could use that public process, we would definitely be interested, and you are more than welcome to provide any input there. Next slide. And as usual, you all know how to get a hold of us, but the best address is HOC.info. That will get it to the appropriate person. And we are constantly getting questions and input from you all. We appreciate that. So please keep that coming. Any topic issues or problems that you have with the prioritized list or items for EGBS, we would be very interested in hearing. Any questions or any concerns or any input for me or for the HERC? All right, thank you all. You know how to get a hold of us, and hopefully everybody stays safe and doesn't has a safe and hopefully not too bad Omicron surge.
As we all cross our fingers and toes. Thank you, Ariel. Okay, before we transition into quality performance improvement update, are there any last minute medical things that we want to put on deck? Questions? Lisa, please go do this before you get to start with Dana Harganani. Otherwise, I already have the list from this morning's session of what we need to follow up on. Okay, well then I'm going to go ahead and go into the next slide, please, Jennifer. So in the spirit that Ariel started, you're going to hear a lot about cancellation. So you have already hopefully read your emails that there's no afternoon session. So as soon as I'm done with this next slide part, we are going to conclude QHOC. So there is no QPI session. I'm trying to figure out what's going to happen in the future. So as of right now, it's January. Not sure about February. We're just kind of rolling with where Omicron surge and capacity goes. I do have some quick updates for everyone, and so we'll cover these, and then I'm happy to either take questions and or just put placeholders. So the MEP final reporting guidance was emailed out to from Actuarial Services on December 14th. Included in that MEP guidance is if in fact the CCO wants to submit their MEP reporting through TQS, which is the Transformation Quality Strategy, then that guidance is included in the December 14th. If you have any specific questions, either related to, hey, how exactly do I do that? You know, either reconciling what you're supposed to do for the requirements for MEP and to and you've read the guidance, then please drop the actuarial service team an email and they will find me if in fact it's needed. So we're closely in connection about those particular deliverables. CCO specific PIPs. So again, CCOs have 3 other performance improvement projects that relate to their community needs. Those quarterly progress reports are due January 31st. I've not been told by leadership any delay yet. If I do get reported, I will let you know as soon as I know, but nothing has been conveyed to me. The 2021 feedback on CCO specific PIPs, and some of y'all I was able to do an actual call with. Some of you all were rescheduled for a variety of different reasons. Either way, you all will receive something in writing from me, hopefully by the end of this week. So if you have any specific time issue questions related to your CCO specific PIPs, please send those to me as soon as you can, but otherwise expect something by Friday. Next slide. The Mental Health Access Monitoring Statewide Performance Improvement Project. The next external quality review statewide PIP validation is due July 31st, 2021. Again, understand there's COVID, understand there's a surge being projected. As of right now, it's July 31st. If I hear again something different, I will let you know. We want to stress that there will be an equity focus update as part of the validation. So looking at how a CCO is developing interventions to address a particular disparity, that will be part of your planning and or interventions. So more to come on that. HSAG, Health Services Advisory Group, our external quality review organization, will be providing technical assistance related to a whole host of EQR activities, and that will include the PIP validation steps. Next slide. The SUD Statewide Performance Improvement Project. As mentioned earlier, we had hoped to convene that collaborative design meetings starting in our QHOC QPI sessions this month. Obviously, with me getting pulled for a variety of things, including Omicron or COVID crisis care guidelines, et cetera, we are delaying that. So it will begin sometime in spring. I'm hoping March. But I'll know more as the work gets underway with the COVID assignment. So right now, the intention is still to do a QHOC QPI session and a 4th week of the month meeting. That's very similarly how we designed the mental health access monitoring metric. Remember, again, the design for these statewide metric is collaboratively with the CCOs and the agency, in which we're designing the population, the goals and objectives, and the statewide indicator that you're being assessed against all together during these meetings. So if you could please send me, and I know we talked about it the previous QPI session about who the appropriate people are to attend. Obviously, you all come here for QHOC, but we're going to schedule those 4th week of the month meetings. I'm going to have to schedule those now since we're losing a couple of months. And so please send me, each CCO, who you want to be in that 4th week of the month that will be around SUD statewide PIP. I'll also be working with OHA behavioral health team, specifically our addictions team, to bring them into an internal work session meeting structure to support this development. So usually what happens is internal meets, external meets. We say, here's the direction and priorities of state priorities around SUD. Then we talk with you all as CCOs about what does that look like from impact? Does that look like from your particular region, et cetera? And we have this iterative process that goes back and forth between internal and external. I then also check regularly with our external quality review organization for their expertise in regards to kind of the PIP protocol and measurement. So it will be very similar to what we've done in the past in a virtual world. So we are able to do it with the behavioral health integration. So we will just do the same with SUD, but kick it off a little bit later. Next slide. And last but not least, I just wanted to kind of put what's on deck that I'm aware of for QPI sessions. Again, I'll know more about February's QPI session in the coming week, hopefully. One of the things that are going to be coming up to you all, and it is the Exhibit I reporting template and data dashboard. The second thing is the patient experience complaints and grievances. We'll give another Real D status update. We had a Real D update This last month, we'll do some real root cause fishboning internally and bring that back out to you all at a future QPI session. You will also be getting the 1115 waiver OHA Medicaid quality strategy update. So as I expressed in December, the 1115 waiver application is out and was up for comment. When CMS and OHA begin its discussions on the waiver application, then I'll be getting additional guidance on the waiver quality strategy, and there will be updates to that accordingly. Those updates to you all as CCOs who manage the quality work will come through this QHOC meeting. So the current draft of the quality strategy was posted with the application, and then we will have that iterative conversation as the agency responds to CMS's guidance and the changes to that strategy. I will come to you all and give you an update on what those changes are, and then look to you all again for that feedback on operational challenges and then relay some expectations. So that will still be in the QPI session. So if you aren't plugged into that, probably want to be, that's one of the bodies of work in addition to the COVID assignments that is still on my plate and definitely not leaving. And then anything else related to QPI topics, please send to your QPI chair, Laura Matola, and she and I will address those during our agenda setting calls. So that's what's coming up. And just again, a reminder that we, as of right now, intend to have the February Learning Collaborative. So QHOC will run from 10 to 12:30 in February, barring any major, uptakes in capacity. And please do route your information to your chairs, Jeannie and Doug, and they check in with us, Dawn and I, and we will obviously adjust accordingly. But as of right now, we plan to have the February Learning Collaborative. Okay, now let me look at chat box from Tanvir. Is there a plan to cancel meetings due to COVID surge across all HA divisions? You just got something from High Tag. The answer is each division is managing their body of work and their staff accordingly to who's getting assigned to COVID and who is not, and what work can be kind of reassigned to different individuals. The one thing I talked with our chairs about at the end of December when I was notified that I'm getting called back up was we recognize that this meeting at QHOC, at the very least in the morning session, is the primary avenue that the agency has to give OHA or CCO clinical directors, whether that be again behavioral health, medical for sure, quality, give you all the update around COVID. So just very similarly, so when we were in the height of the surge and the height of COVID, just everything when COVID just came, we maybe canceled one meeting, but then it was very, very pressed upon with your previous chair, Dr. Holly Jihad, is that we all needed information related to COVID. So we had to, we had to convene. So the chairs had, your current chairs, Jeannie and Doug, supported that same conversation. I'm working with OHA leadership and recognizing that at least QHOC, at least the morning session has to be staffed and has to be prepped because it is the primary avenue at which we connect with CCOs on the whole host of COVID updates, just like you just had. Like, here's where, how much drug we got coming in. Here's how much vaccine we have coming in. Here's where those coordination meetings are happening. So that is still the intention at the very least. Other divisions and other meetings may not support, may not be directly linked to that kind of COVID information. So they may be canceled in whole part versus this meeting is for CCOs, medical directors, and clinical quality directors, et cetera, that we might have, canceled the afternoon session where we're talking about improvement strategies, and we'll keep the morning to COVID and or other key initiatives like, well, crisis care guidelines, but that's COVID too. So any other questions? Let's see, let me find the chat box. But thanks for the question, Tender. Any other questions for me? And you can raise your hand or put it in the chat. So in the end, no afternoon session for January, probably likely for February. I'm just going to put that out there. I will check in with the quality assurance team on when Exhibit I will be ready. I mean, if they're ready to go February, you don't need me because quality assurance will we'll do that one. But again, we have to respect where your time is at as well. So we'll check in with your chairs, we'll check in with the QA team and see if that's going to be teed up for February. If not, then most likely it will be canceled. February is my guess. I will send each CCO quality staff their PIP for CCO specific. You have information related to your PIP validation for your statewide integration mental health access monitoring. And no changes to TQS that I've been notified thus far, as far as delivery date. Okay, Jeannie, Doug, you guys are letting me off the hook with no questions. Unless you guys have something, we get to give the gift of time back.
Nothing from me.
No.
Okay, Dawn, Laura, and Jeremy, behavioral health. So if your chairs are all good, I'm good, and everyone gets to have a little bit of a longer lunch break.
Lisa, I'm good.
Happy
Thank
New
you
Year.
for asking.
Be safe, be healthy, and we'll get through it. Thanks all.
All right. Goodbye.
Everybody stay safe and healthy out there.